Hello everyone. Today's session is for the GNM second year and the topic is congenital hypertrophied pyloric stenosis. Congenital means inborn, hypertrophied means increase in the volume of an organ or tissue due to the enlargement of its component cell. Pyloric means lower portion of the stomach, that is pylorus part. Then stenosis means abnormal narrowing in the tubular organ or structure. So congenital hypertrophied pyloric stenosis means it is an inborn disorder which occurs when the muscles surrounding the lower opening of the stomach gets too large and constricts the opening. So here is the introduction. Congenital hypertrophied pyloric stenosis is the most common intra-abdominal. Intra-abdominal means within the abdomen. So it is the most common intra-abdominal condition during the neonatal period which requires surgery. It is generally occurs in infants between 2 to 8 weeks of age. So the definition is congenital hypertrophied pyloric stenosis is defined as narrowing and obstruction of the lower portion of the stomach, that is pylorus, that prevents food from moving from the stomach to the intestine. Now the incidence rate, it affects 1 out of every 500 to 1000 live births. Etiology, the exact cause of congenital hypertrophied pyloric stenosis is not yet fully understood. Now the pathophysiology. There is a diffuse hypertrophy and hyperplasia of smooth muscles of pyloric sphincter. Because of the diffuse hypertrophy and hyperplasia of smooth muscles, there is a narrowing of pylorus with partial and then almost complete obstruction. Because of the partial and then almost complete obstruction of pylorus, it prevents food from moving from the stomach to the intestine. Because of this, there is an attempt to push the food forward through the obstruction, which causes the vigorous peristalsis movement. Because of the vigorous peristalsis movement, there is a persistent vomiting and dilated stomach musculature, which develops dehydration in infants. Now the clinical manifestation. Initially a child is having regurgitation and a non-bilious vomiting both during and after feeding. Then the child presents with other classical features like constant hunger, dehydration, irritability, projectile vomiting. In projectile vomiting, the vomitus is through several feet from the infant. It is a main feature of the pyloric stenosis. Note this point. Projectile vomiting is the main feature of the pyloric stenosis. The projectile vomitus contains gastric contents, mucus and streaks of blood but does not contain bile. Next is constipation, decreased quantity of stools and urine output, and lethargic. Now the diagnostic evaluation. First we have to collect the history, then we have to do physical examination, then abdominal x-ray, then abdominal ultrasound, complete blood test, serum electrolyte and barium meal x-ray. Barium meal x-ray is a procedure in which the physician examines throat, esophagus and stomach. This procedure involves drinking white liquid called barium and then x-ray pictures taken. A barium meal x-ray study reveals delayed emptying of gastric content as well as narrowing of the pylorus, which confirms the disorder. Then management. Pyloric stenosis is treated in 2 stages. Initially, fluids are given IV to treat the dehydration and restores the body's normal chemistry. Once we treat the dehydration, then an operation called pyloromyotomy surgery is performed. It is a type of surgery which is done to widen the baby's pylorus. In this, surgeon makes an incision in the wall of the pylorus. The lining of the pylorus bulges through the incision, opening the channel from the stomach to the small intestine. This surgery is performed at the age of 4 to 5 weeks. Now, the nursing management. In this, first is preoperative care. In this, first we have to administer IV fluids as necessary and prescribed to correct fluid and electrolyte balance. Then record urine output, vomiting, number of stools, and vital signs. Then provide small frequent feeds to the child and burp frequently, and place the baby in upright position. Then assess daily weight of the baby, provide NG tube feeding if necessary, and stomach wash with normal saline should be done 6 hours prior to surgery. Then in post-operative care, monitor and record vital signs and behavior of the child. Then watch for any abdominal distension and administer IV fluids as necessary. Thank you.